Since then, other types of antihypertensive drugs have been created, like beta blockers. So with beta blockers, the action is that it blocks the effects of the catecholamines on different beta adrenergic receptors. So epinephrine, which is secreted, and norepinephrine from the sympathetic nervous system and from the adrenal medulla. So think about it. A person gets really nervous or uptight, and they secrete these catecholamines, don't they? Or I'm doing any kind of aerobic exercise, and I'm releasing more of these things into my bloodstream, and my heartbeat is now faster and it's beating stronger. Isn't that correct? So there are different beta adrenergic receptors on cells. There's the type 1 beta adrenergic receptor, the type 2, and the type 3. The beta adrenergic receptor type 1, and this is the important one for us, is on the heart and on the kidneys. So when I have excessive sympathetic drive, whether it's from psychological issues or physiological issues like exercise, then I'm going to affect those receptors. But I'm also going to affect the beta 2 adrenergic receptors sort of on my internal organs, sort of the lungs, the GI tract, the liver, the uterus, vascular smooth muscle, and skeletal muscle. And the beta 3 receptors are on fat cells. So isn't it true that if I do aerobic exercise, it helps the fat comes out of the fat cell, flows through the bloodstream, and the muscle burns the fat through beta oxidation? How does the fat get out of the fat cell? As I get to a certain level of intensity in my aerobic training, I get into the target heart rate zone, adrenaline is released, or epinephrine is released. It stimulates the beta receptor on my fat cell, which then stimulates hormone-sensitive lipase inside the fat cell to hydrolyze my triglycerides. Now the free fatty acids can float out into the bloodstream, attached to the protein carrier known as albumin. Albumin will carry it through the bloodstream. My muscles doing the work will pick up the fat and burn it as a source of ATP energy. So the beta 3 adrenergic receptor is on the fat cell, also stimulated by those catecholamines. So the beta 1 stimulation, when the beta 1 adrenergic receptors are stimulated by those catecholamines, then I get a positive chronotropic effect. The heart rate speeds up. I also get an inotropic effect. The force of contraction of each heartbeat also increases. So I get a systolic pressure increase, and I increase conduction velocity through the heart itself. So in the flight or fight mechanism, if I'm running away from the predator, then I want my heart to beat faster and pump with more blood to get more oxygen out, and I need better electrical conduction so that I can keep all of this happening. But here's what happens in the kidney. And this is what explains largely how aldosterone gets into the act. And that is with sympathetic discharge, and I'm releasing these catecholamines, the juxtaglomerular cells on my kidney release renin. And renin then, and we're going to see this momentarily, renin is then going to convert angiotensinogen, which is made in the liver, into angiotensin 1. And angiotensin 1 is going to become angiotensin 2 as it goes through the pulmonary circulation. And angiotensin 2 is going to actually increase my aldosterone levels and do other things that will raise my blood pressure. So when there's increased sympathetic discharge, I'm also stimulating the renin, angiotensin, aldosterone system, and we'll see that how that in people that have chronic blood pressure problems that are elevated, why just even psychological stress or our deep-rooted emotional issues can actually perpetuate the high blood pressure, and where meditation, visualization, aerobic exercise can actually work to tame this system down as part of the management. The beta 2 receptors, when they're stimulated on smooth muscle, cause vasoconstriction of the central and visceral blood vessels. So if I cause vasoconstriction, then it raises my blood pressure. There's more resistance to the blood flow. Whereas it's going to dilate blood vessels that go to my muscles, right? If I'm running away from the predator, I want more blood going to my skeletal muscle, less blood going to my internal organs and digestive tract. It's also going to cause a little more tremor in the muscle, and it's going to cause glycogenolysis. I'm going to break down more glucose in my liver and release it into my bloodstream because it becomes a fuel for my muscles. My body assumes I'm in the fight or flight response, and I need for the heart to beat faster. I need my blood pressure to be raised. I need blood going to my muscles. I need more glucose in my bloodstream. But actually what's really happening is that the person is just chronically stressed, and so they're in a sympathetic dominant state. And so when you're in a sympathetic dominant state, you know what else happens? You get headaches. Your trapezius muscles tighten up. You get neck, upper back, and shoulder pain. And so you go to your doctor and they give you blood pressure medication. You go to the chiropractor and they give you this particular treatment. You see an acupuncturist for that. You see a massage therapist for this. But what's really driving all of this in behind the scenes is this altered physiology that no one's really paying attention to. And it's lifestyle medicine that can actually undo the underlying problems so that the reliance on all of these things drops down to what it should be. The beta-3 stimulation, of course, more fat leaves the fat cell. And so what they've tried to do is they've tried to make drugs, beta blocker drugs that are cardioselective. That means drugs that will act only on the beta-1 adrenergic receptors so they don't mess up all the other things going on in the body. But as you get to higher doses of even cardioselective drugs, they do stimulate the beta-2 and beta-3 adrenergic receptors as well. So where would you give somebody a beta blocker? If the beta blocker then is going to inhibit the action of the catecholamines on those beta adrenergic receptors, then I can slow the heart rate, I can decrease the blood pressure, I can stop excess release of renin from the kidneys, and I have all these other effects where adrenaline can't affect the internal organs quite the same way. So where would I do that in a case of angina, where you want to try to get a negative chronotropic and inotropic effect, decreasing cardiac workload and oxygen demand? So if the heart doesn't have to contract as hard and it's not going to contract as fast, then the heart muscle demand for oxygen is going to be less. So in addition to lowering blood pressure, they might be used in a case of angina just to decrease the oxygen demand by the myocardium. For people that have arrhythmias, very often you have this excess electrical conduction going through, creating this aberrant type of firing pattern where you lead to an arrhythmia. If I can block some of those adrenergic receptors from the sympathetic nervous system and adrenaline, then I'm going to help to manage the arrhythmia better. And then, of course, in uncomplicated hypertension, I'm going to block the effects on the heart and on the kidney so that I bring blood pressure down. The heart's not contracting as hard, not as quickly. I'm not releasing as much renin. There's less aldosterone. I'm not resorbing as much sodium and water into the bloodstream. So I'm getting all of these effects on the heart and on the kidney to bring blood pressure down. So in certain types of patients, beta blockers become a better choice than a diuretic drug. Here's some considerations. Beta blockers can impair the relaxation of the bronchial smooth muscle, so they can't be prescribed for an asthmatic. This is a classic exam question. Think about the fight or flight response. My sympathetic nervous system gets into the act. I want to bring blood to my muscles. I want my heart to contract harder. I want my blood pressure to raise up. But I also want to dilate the bronchial tree to get more oxygen into my lungs and diffusing into my bloodstream. So the catecholamine effect on the lungs is that it dilates the bronchial tree. If I block that effect with a beta blocker, because I'm trying to lower blood pressure, I also block the effects in the lungs. I cause constriction of the bronchial tree, and I make asthma worse. So in an asthmatic, beta blockers are contraindicated. What's interesting is that in glaucoma, which you have studied now, where you have a buildup of pressure in the anterior chamber of the eye, you follow this? So you understand what I'm talking about at this point? So they now they can lower the pressure by giving people topical beta blocker drugs. So and it works to help to manage it. But the beta blocker then diffuses into the bloodstream and can have these other systemic effects. So you need to be on the lookout for side effects from beta blocker drugs and people even using it topically, as we'll see. And a number of years ago in the Olympics, these biathletes, these Olympic marksmen, you know, where they cross-country ski, and then they jump down into the snow, and they have a rifle, and they have to shoot a particular target. This is the biathlon. Is it correct? Is that what it's called? Am I correct? Yeah. And so because catecholamines increase muscle tremor, as we saw earlier, if I can block the effects of the catecholamines on the muscle beta adrenergic receptors, then there's less tremor, and I can fine-tune my shot. So beta blockers are banned by the International Olympic Committee for athletes involved in sports like this. And so you take 220, you subtract your age, you get the maximum. And then you know that somewhere between, and this is debatable, 55% and say 85 to 90% of that maximum for that person is the aerobic training zone. Most of us would agree on that. The problem is that when someone's on a beta blocker drug, because the heart can't respond to exercise the same way because you're blocking some of those receptors, that you have to adjust the aerobic training zone chart down by 10% to make it realistic for a patient who's on a beta blocker drug. See the importance here? You start pushing the person into, you're saying you got to work harder to get your heart rate up. They're on a beta, you can actually put them into an arrhythmia or actually cause sudden death heart attack or a major cardiac event because you're pushing them too hard. You're actually going into an anaerobic zone, but you think they're in the aerobic zone because you're not factoring in the effects of a beta blocker drug on the heart, which mitigates against some of the natural effects of exercise. These are adverse side effects of beta blocker drugs. Take a look at what the beta blocker drug can do to bring patients into your office. You think this is the primary complaint. They come in like they have Raynaud's syndrome. They've got their hands and their fingers are very, very cold, and they have all this sort of pain and coldness and tingling into their fingers. You're saying, oh, maybe there's nerve pressure in the cervical thoracic. Maybe it's the first rib on the right. You're looking for musculoskeletal stuff. You say, have you started any new medications lately? Oh, yeah, I'm on propranolol. This could be a side effect. Did you speak to your doctor about this? Well, I mentioned it, but he or she didn't seem to think it was a fact. No, this can be a very common. I will do my assessment, but this can be a side effect to a beta blocker drug. Also, slowing of the heart rate, as you know. Orthostatic hypotension. The person stands up out of a chair and they're lightheaded. Fatigue and dizziness, insomnia, nightmares. Clinical depression can occur. Just in the odd person, it can be all of a sudden the person who was healthy-minded, all of a sudden they're feeling really depressed. And it gets missed. It's like, well, this could be a side effect. The most common reason for men to not use their beta blocker drugs is because it creates erectile dysfunction. So the vasodilation normal effect from arousal doesn't occur, and they can't get a normal erection. So in most cases, high blood pressure has no symptoms. Not having sex for the rest of your life has symptoms. So what normally happens is the man has to decide, let's see, am I going to take the beta blocker drug and I can never have an erection again? Or I go off the beta blocker drug, I don't even notice because the blood pressure has no symptoms day to day, and I get to have sex. So men just stop taking beta blockers and they don't mention it to anybody. And a lot of men walk around in this world, and you're going to see them, with blood pressure problems that are not controlled. A very high percentage of people with high blood pressure, it's not controlled because they don't like feeling the lassitude and fatigue from the diuretic. They don't like not being able to get an erection when they're on a beta blocker. They say, you've got to come up with something better than this. 2007 study showed that diuretic drugs and beta blockers used for hypertension actually increase risk of future onset diabetes. So at least in Great Britain, what they're saying is we don't even like using diuretics and beta blockers anymore. We'd rather put the hypertension patient who doesn't have any complicating factors. They don't have angina, they don't have congestive heart failure, they don't have arrhythmias. When it's just a straight blood pressure problem, we'd rather have them use an ACE inhibitor or an ARB, which we're going to see very shortly. But in North America, diuretics and beta blockers are still the primary drugs used, even in these uncomplicated cases. You'll be able to recognize the beta blocker drugs when you look at the generic names, when you look these things up, because they often end in the suffix OLOL, like metoprolol, propranolol. They often will, if they end in OLOL, you can bet your bottom dollar that's going to be a beta blocker. And there's gazillions of them. So the patient will come in, you'll see they're on a hydrochlorothiazide, and they're on, propranolol, and you'll say, oh, this, diuretic, beta blocker. And if you don't know, look it up, and you'll say, oh, it's a beta blocker. Okay, I know what that does now. But I want you to see this once because it's going to factor into how the next class of drug works as well. So Here you see on the cells, here's the adrenaline fitting into the beta adrenergic receptor. You see that? When it stimulates the receptor on the cell surface, the next thing that happens is that you get this, these intermediate signaling agents of GDP becoming GTP. GTP then sort of affects ATP to upregulate cyclic AMP. And you're going, why are you telling me this? Because once you have cyclic AMP, so here we are again, here's norepinephrine affecting the receptor, upregulates GTP, and then GTP can access and increase the amount of cyclic AMP. Cyclic AMP does the magic. It's a very important second messenger in the cell. Cyclic AMP goes to the sarcoplasmic reticulum of the muscle cell, in this case the heart muscle cell, and tells it to release massive amounts of calcium. The calcium, of course, then travels over to the myofilaments, and it unlocks the troponin and cross bridges. You know this from exercise physiology. I unlock the troponin and cross bridge, and now the muscle filaments can slide, and I get muscle contraction. So the more intracellular calcium there is, the greater is going to be the force of contraction, because I can unlock a greater number of troponin and cross bridges. You'll notice that the GTP also opens up these calcium channels and allows calcium to flow from the extracellular space to the intracellular space, and it too then can activate these contractile bands. So what catecholamines are doing in the heart is that they're releasing more calcium for muscle contraction and opening up the voltage gate calcium channels to allow more calcium to flow from the extracellular space to the intracellular space to activate more muscle contraction. At the end of muscle contraction, of course, there's a calcium-sodium exchanger that's going to pump the calcium back out into the extracellular space. So pay attention right here. What if the heart muscle is really weak? Heart failure, congestive heart failure, cardiomyopathy. And you're saying, how am I going to get this heart a little bit stronger? So I give the patient, we'll see this later, digitalis. What does digitalis do? It blocks the sodium-calcium exchanger pump so that the calcium can't be pumped back out into the extracellular space. More calcium remains intracellular, and so I get a greater amount of muscle contraction, even in a heart muscle that's sort of weakened a little bit. I can make it a bit stronger with digitalis. Does that make sense to you?